Per favore chiamate anche le persone fuori.
If you could kindly invite everybody who's still outside to be seated, we can start. And the first aim of this session is to give families an opportunity to ask questions and raise issues. We have 45 minutes. And during these 45 minutes, parents can, as I said, ask questions and address them to clinicians. Obviously, this is also an opportunity for you all to ask questions on the basis of the inputs that we've received. And then after that, we will start with our session on genetics, and then there will be another Q&A session at the very end.
Dunque, abbiamo il ragazzo col microfono.
We have a roving mic, and let's see who would like to start asking questions. Please introduce yourselves when you do take the floor, and please indicate who the question is for. Thank you.
Nessuno? Allora, l'anno scorso ci avete criticato perché non siamo...
Nobody? Oh, because you see, the reason why we introduced this Q&A session now for parents' feedback is because last year, or last time we met, we were criticized because there wasn't enough time for parents to ask questions. Oh, there is a dad over there, I believe, who has a question. My daughter is called Gaia. And at 5 months, after 8 hours from a booster shot, she started having this onset. I'm wondering whether behavioral disorders can be linked to the side effects of drugs. My daughter's now 18, and I've noticed that before and after the administration of drugs, her behavior patterns change. I obviously know that there is a mutation, an underlying mutation, but I have the impression that drugs also have a side effect, and I'd like your comment. Then we talked about language acquisition disorders. My daughter was 4, and we didn't know of this genetic mutation at the time. And she was hospitalized, and there was never a diagnosis of mental retardation or cognitive disorders. And for 4 years, everything seemed normal because my daughter, and we have this on video, talked. And that year, we started administering Topamax, and her language skills were completely blocked. She was on this drug for 2.5 years, and she was less reactive with fixed gaze when we suspended this drug. She was more interactive. She looked at us. She started talking, but never recovered fully. So I'm wondering if some drug side effects can have a permanent effect on some of these girls' language abilities. That is actually more than one question, 2 questions, really. Professor Vigevano perhaps could answer the first question on the correlation between drugs and behavioral disorders, and to what extent drugs can interact with the condition of epilepsy. Going back to what Marina said in her presentation, it would be important to identify the drugs that are contraindicated, both because they can trigger seizures and cause side effects that can, worsen behavioral disorders. Now, the fact that topiramate or Topamax could give mental disorders is something that has been recognized, and you have seen this for yourself because you did notice that there was an improvement in performance. But once again, it's a case of obtaining more data. We need to put together several cases to observe these side effects to understand which drugs are contraindicated. In Dravet's, it's easier because it's about the type of drug that interacts with a certain genetic mutation. In this case, we don't have that certainty. Thank you. I have a question for Doctors Ragona and Darra. I don't know if I fully understood their presentations. I might have misread something, but if I'm not mistaken, at some point, I don't remember who said this, but at some point there was mention of the fact that 8 of the patients in the register are seizure-free, despite the fact that they are taking Keppra, and 8 of these are in this condition. And my daughter has been seizure-free for a while. I mention this because of this, and I'm saying this also in the light of what other families have indicated. And there are some girls who are on a monotherapy treatment with Keppra and are seizure-free for years. I'm wondering if you could comment on this. I'm wondering whether with these groups of girls who are good responders, would it be possible to carry out a clinical analysis to establish the actual impact? Would it be possible, for instance, to see if there is something in common, and if, for instance, these groups of patients respond well to the drug? I hope I was clear. I'll try and answer your question. As shown by Marina when she showed us this review of publications on PCDH19 treatments, and we saw that when it comes to structured and certain answers, these are not to be found. All of the literature reviews are based on retrospective studies. There are no prospective controlled studies, so we can't speak of evidence at first, because this is a rare disease, and also because there is no possibility of having prospective studies as yet. We are trying to put together as many cases as possible to see which drugs are most effective. The work we've done, and I apologize because when we went from my PowerPoint to the other one, some of the charts were shuffled, and so a few things might not have been as clear as they should have been. But you might recall that when we compared seizure-free patients under treatment and those who continued to have seizures, we observed that most of the seizure-free patients were more frequently taking carbamazepine and levetiracetate, with the remark that we were talking only a few cases. Obviously, we had steribental. There were some suggestions, and we know that with respect to carbamazepine and steripenthol, there might be more effectiveness with respect to others, but this is not enough. And if we look at the seizure-free subjects, 8 in all, we had very few who were undergoing a monotherapy. And of the 8 that were seizure-free, only 3 were on levetiracetam exclusively. Others were taking valproic acid, and yet others were taking Capra. We don't have sufficient instruments to answer this question. And obviously, to put together the clinical data that we're discussing will enable us to develop some correlations, because if we do have data, we can create correlations. We can try and correlate so that there are factors that impact more or less the effectiveness of a treatment. So it is a suggestion that comes from our registry findings and literature. But for the time being, this has to be confirmed. And the group is too small for the time being. However, if we take a retrospective approach, look at all the variables and the case history, there could be some indications.
Io invece volevo girare la domanda.
I would like to ask pure researchers the following question. Are there some drugs that, given their mechanism of action, can be more effective, acting on GABA or other channels? Do they have any insights which could indicate which AED is likely to be more effective? If I could, maybe Maria would be the right person to answer this question if she's prepared to. Talking about GABA. You need to wait for the microphone. Just raise your hand so that the technician knows where you're seated. Well, for instance, we do have evidence that the GABAergic system is involved. There's a cross-link between prostaglandin and GABA receptors. However, I'm not the best person to talk about drugs. This said, I think that many AED already have that impact on GABA. I can add that my presentation will be on this, and maybe clinicians could give us some feedback. And maybe we could have a discussion on this. Personally, I would know.
Sì, sono d'accordissimo con.
I agree with Silvia, but I would also like to add that there is a long debate and argument on other autism spectrum disorders on the need to control intracellular chlorine levels. There have been some clinical trials using diuretics to try and reduce cellular chlorine. What we do on GABA is meaningful in as much as target neurons have a normal homeostasis of chlorine. Otherwise, GABA, in Downs, in Alzheimer's, this is known, can have the opposite effect. And we know too little. We see that there are drugs that have opposite effects, and we don't understand the cellular basis for this because there are some pieces in the puzzle that are missing. So GABA is clearly a complicated target, and therefore, really, there are gaps in the knowledge that we have. And in coming years, they will have to be filled. This must happen. To go back to the question that was put to us by the chair, by Francesca. There are several Francescas. Francesca Chair. Well, the answer is that there's no answer. And I'll explain what I mean by this. Even the data that's been derived from the register compares the treatment of seizure-free patients versus patients with seizures at the follow-up stage. All studies that have attempted to correlate response and treatment do not take into account the moment in which the drug is introduced. In other words, in situations such as PCDH19, we know that the most critical phase is in early childhood, and then progressively there are fewer cases of, let's say, non-reaction to drugs. In order to really compare the effectiveness in modifying their natural history, we would have to stratify this by age, because there are some subjects who respond to levetiracetam or oxcarbazepine or valproate, but their age is such when the drug is introduced that they are less resistant. So there would need to be a longitudinal study to see whether it is true that levetiracetam or loxocarbamazepine or valproate are effective when they are introduced at an earlier stage. This is what I was trying to explain this morning. Either we have longitudinal studies, otherwise we can only say that these drugs, steripenthol, carbamazepine, are those drugs that are more correlated to seizure-free subjects. We don't know, however, if they are more effective than other drugs in terms of stopping seizures in the pre-follow-up stage. This is clear. I understood this. But this was a proposal. As a non-expert, the question was whether it would be useful to start from the results as an attempt. At times, serendipitous moments do occur, and we have these 8 girls and who take Keppra in their multi-therapy. Is there something they share in common? Are there any points in common of significance? If that were the case, maybe it would be worth attempting to use that drug, because we have to go by trial and error when these girls' drugs are changed. And that is why I said, can we make an attempt on that basis? Obviously, this is not a scientifically rigorous approach. I understand that. It was just a proposal. I understand, but you need numbers. You cannot compare 8 against 8 and 8 and then 150. But we have to start somewhere, yes. But since the subjects in question who take levetiracetam or oxcarbazepine, we would have to look at responders and non-responders, all treatment conditions being equal. And we have to see that 50% take levetiracetam and 50% of seizure persistence take levetiracetam. And if you just look at that, yes, you're right. But the problem is that we have to take a step back and differentiate between responders and non-responders. That would already be a great achievement if we were able to do this. Those who respond to any type of drug versus all those who do not respond to any of the drugs. But if I may, going back to the issue of treatment, going back to what a parent said, if we look at Dravet syndrome, the take-home message ought to be that when a diagnosis is achieved, when we have a PCDH19 syndrome diagnosis, the conditions are not characterized exclusively by persistent seizures over time. The situation is characterized by a greater or lesser likelihood of having problems in terms of cognitive or neuropsychological competence and a high risk of behavioral disorders, which means that from the very outset, one must be very cautious in evaluating the development profile without waiting for something to be considered as normal until there is, I'd say, a turning point, because it is only thus that we can intervene in such a way as to achieve results. And this is true also with respect to behavior, because those who have OCD when they grow older or more severe conditions already have a history of hyperactivity, behavioral disorders, opposition, and these are aspects that when they're little are underestimated because of the seizures prevailing. And the message is not just for the family members, but also for physicians. We have to look at the big picture. We have to identify symptoms as early as we possibly can. We mustn't just think, okay, drugs are taken in the event of a seizure. We have to try and avoid a worsening over time of the conditions of the patient.
Buonasera, sono la mamma di Sara, che adesso ha 12 anni ed è libera da...
My daughter's name is Sara. She's 12 and she has been seizure-free for 4 years now. I would like to ask the following. How many new cases are diagnosed every year? And since we're all talking about the importance of collecting data for the registry, I would like to know whether new cases are all included in the registry, because it's one thing if we look at the stock of girls whose onset was 15 years ago, and maybe they've had a new treating physician, and it's another matter if we immediately include data on new patients in the register, and this could be a way of focusing on the information that appears at the moment of outset, because we know this is important, even though this cannot give us any insights on treatment and its effectiveness. Maybe Dr. Aragona could reply. The number of quantifiable cases is not sure. Maybe we can say that there have been cases of physicians who've gone back to look at cases that were in the pre-genetic stage as far as information goes. I think there's 1 or 2 new cases a year. We see less than 1 new one a year because we don't have access with A&E. So maybe once a year, no more than that. Obviously, accredited centers are invited to include data on all new patients. And we know that there are very small patients in the register. And data on our onset of the disease are those who refer to better descriptions. And for instance, we have a patient who might be 15, there might be some information, but we know exactly when the date of onset was and other details, because this is something parents obviously remember. And this is in the case for adult or adolescent patients.
Giusto, volevo aggiungere, noi abbiamo fatto quest'anno.
This year we made 2 new diagnoses with young girls aged 1 or 2 years, and we also had a patient referred to us from Sicily, and she was referred to our own lab. So we had 3 girls, 3 diagnoses. Probably there should be some other cases in other labs, and I believe that this is going to be more or less, or is more or less, the incidence on a yearly basis. It would be interesting to study this as well, I believe. I take the liberty of taking the floor. I work in Brescia, and in Brescia we have some 12,000, 13,000 children born on a yearly basis, and whatever happens in Brescia or in the province is referred to us, unless it's between Brescia and Verona, which sometimes may be referred to Verona. Let me just make a few calculations. In 20 years, we made 5 diagnoses. The 20-year-old was the most difficult one, and in last 8 years, she had 4 different diagnoses. So we should never get it wrong anymore. And in the last 7, 8 years, we shouldn't get any diagnosis wrong. So let's say that if in the time span of 20 years, I have some 20 children who are born, out of them 5 have the condition, well, and I'm referring to Brescia because Brescia is the periphery of Milan. There are no other references. Whatever crisis, whether febrile or not, has been referred to us. And since I start from this, because whenever I am confronted with a rare condition, I wonder, why is it that I see just 1 when my colleagues see 20? That means that I'm not good at making diagnoses. And so you have to work on diagnosing. So I think that the frequency in diagnosing, as far as Brescia is concerned, is 1 case out of 15, 40,000 sometimes cases on a yearly basis that are being screened. And if I have had the great bad luck of working in a place where all of the cases are being referred, and in that case we can diagnose them. So I think it's quite significant that in Rome you have 2 cases, 2 Romans, right? And I think that Rome, just like any other large centers, do not just see the local population. So what happens? I believe that this is the real frequency, and I'm really considering it for all of the other syndromes, because if the figures tend to vary in other cases, then it means that I'm not good at diagnosing the conditions. And I can tell you what are the Brescia data, and I think that that could be a good idea. They have been well studied, well thought, and this is a good input for you. Now, I guess that they have been fed into the register. And if I may say, I would like to say, just as an evidence of helping the families who are here today, I would like to say that each one of us will have, starting from Monday, will have to check and double check with their own treating doctors if the medical history of their own daughters or sons was fed into the register and filed there, because sometimes we know that we have more than 55 cases in Italy. I think it's more than twofold. It's more than double. And this is what we can do from the mapping profile point of view, as to the mapping of cases, I mean. There's a mother down there, I guess. Oh, Joseph. Joseph, please.
I would like just to comment on some of these discussion points. I will also mention a little bit in my talk. I think we need to go beyond Italy. We need to go global. We need to have a global register. It's good to have Italian register, and it should be. There is a register in the United States, maybe in some other countries, but we need to find, and we were thinking about it, and we have 1 or 2 websites where we can pool this kind of information from hundreds of patients. Because according to the Scottish study, there is 1 in 20,000 girls born, 1 girl with PCDH19. So in Italy, you would have between 20 and 40 cases annually if you were going to diagnose each one of them. So it's quite a lot. So worldwide, we're seeing thousands of these. We need to find a way how we can bring this wealth of knowledge together. We cannot design prospective studies because we cannot experiment with these girls. And you as parents, you can tell us, would you let really people to tell you what to do, which drug to take, on or off, when and how? It's not ethical. So clearly everyone tried to help these girls or boys as much as they can, using all different routes, and for some this will work, for the others that will work. But we need to capture that information effectively. So we need to have Italian register, we need to have global PCDH19 information exchange, or we know it works. It works from other diseases, we know it works from other fields of endeavor. It's just the clinical as well as the parents, communities should not be afraid to share some of this information. It takes some effort, it takes some time to subscribe to registers. There might be a few hours of finding information, filling boxes, but it is worthwhile. Every single patient makes a difference.
Stavo proprio per dare un attimo la parola.
I was about to pass the floor to Isabella Brambilla. She is the president of Italia Onlus and the promoter of this register for the Dravet syndrome, but also for the PCDH19. So the question I'm turning to you is, are you thinking of creating a correlation with the existing registers? There's one we know in the United States, and I believe another one in France, if I'm not wrong. I can think of the French doctor who's in charge of this register for PCDH19. I know that there is one anyway. Well, after the Italian experience, the register was born some 6 years ago. We have some pilot centers, 22 hospitals that feed in the data from all over and across Italy. And I would like to thank all of the doctors, because this is an extra work that they do, especially in the initial stage where they all have data and feed them in retrospectively and do every year the follow-up. Well, this really deserves a big thank you, because it's a great effort. Now, after this incredible positive experience, we've developed a European register. It was born on the same database. 6 pilot centers were involved. One is France, Rivana Butta, England with Ellen Cross, Glasgow with Suberia Brunklaus, and Denmark with Professor Ruboli. Belgium and the Netherlands with Lila Gay and Professor Kuhlemann. And we know that basically these are the reference centers that joined in the project. The project was started a year ago. We are pooling ethical data, consensus. We've started feeding in the data, and we have a first deadline for next December, next year, I mean, so as to have the same case numbers as in Italy being developed elsewhere in Europe. Other centers want to join in. There is already a accredited center in Spain, Croatia. We've received some applications from other extra-European countries such as Saudi Arabia. So in our case, we want to make the best and the most of this tool so as to create new evidences. And little by little, thanks to the collaboration of doctors, we would like to develop the register with other European centers, which might prove to be helpful. So everything is welcome. Next month, I'll be in the United States with the American Epilepsy Society, and that will be the right moment to confront ourselves with respect to PCDH19. And I believe that this is one incredible opportunity, and I'm the first one pushing hard towards that direction. Please, there is someone else, I guess. The mic, I'm afraid, is off. I can't hear. Good afternoon. My name is Maria Teresa. I am the mother of Valentina. She had a first seizure when she was only 5 days old. The treatment with Depakine, Tegretol, and Lamictal. And I may say that in the past 3 years she's been seizure-free, but she's developed behavioral problems. And she has lots of moments of marked opposition and denial, and that's a big no. Big no. And whenever she's confronted with that, she breaks everything, she crashes everything. And I heard from some doctors that she suffers from a dysfunction of negative emotions, so she cannot control them. And that means that should I see whether she is to take new drugs, other drugs, different drugs. The ones she's already taking are rather heavy on her. And what am I supposed to do? This is my question. How should I approach this? And then the register. Well, yes, my daughter is registered in the list of rare diseases under a different name, not the PCDH19. So I wonder, how is it possible? I would like to have a register for PCDH only, where the different traits and characteristics might emerge, so as to allow to see clearly the data and the traits of these patients, because we know that when they become major, they are lost to the national health system. As to the register, I can already answer to you. There is a PCDH19 register. Where are you followed up? In Umbria, the region? No, which hospital? Which hospital? Silvestrini, Hospital Silvestrini in Perugia. Is that accredited center? Yes, it is. It's in the network. You mean credited to our register? So what should we do if there is a family who would like to have the data registered? So you have to credit that the center at regional level. No. Let me make it clear. The question is different. The point is whether the Perugia center is joining into the specific register PCDH19. I've been told that no, that's not the case. So you should register it. Maybe you should, if they do not join in, you could go and see whether a different hospital could allow you to have your data fed into the register. Any volunteers may be here in the room? Any other hospital representatives that may volunteer? Okay, I have the great bad luck of being even more negatively struck by bad luck, because I would never want that starting from tomorrow morning series of misunderstandings may sort of be backlashing us. So I haven't really well understood. Is that woman, that lady, referring to this register, or was she referring that in the list of the acknowledged rare diseases, the PCDH19 is not listed? Because when considering the possibilities, we know that it's there in that register, that the data have to be fed. And it was hard enough to have the Dravet syndrome being registered in the register. And so we would want to have PCDH19, which as of today is not recognized as a rare disease, and it should be listed in the list of rare diseases as well, because that is what makes the difference in terms of extra possibilities or additional possibilities. I wouldn't want to say advantages, but I think that that's the minimum that should be granted. Now, as far as instead is concerned, the register, one thing needs to be made clear and has to be clear. As of today, it's possible to have centers that are credited with the register accept the patients, and that is because the information that needs to be fed into the register need to be validated from the medical point of view and not only from the family point of view. Family, because the family members are the ones that support and assist the patient. And then those who do so, who do feed the data, are accepting to still go on doing it in the following years, because otherwise the purpose is lost. So we don't want to have a register just to know how many PCDH patients do we have in Italy, but rather to try and build up a natural history of this disease. So the family should be insisting so as to have the PCDH listed into the register. And there are two possibilities, and the choice has to be left up to the carer, the national health carer who treats that patient. And then other thing is the center following up that child that needs to be credited, and the application to be credited is free. It's on a volunteer basis. And if the center has just one patient, obviously they will deem it extraordinarily heavy to do all of the procedures. And so you have to make an agreement with the credited center so as to allow that patient to be listed into the register. Obviously, you have to become committed to passing and feeding in information whenever you do some updating, and you have to feed it to the ones who are credited to do so. Is that clear? Now, what about the list of rare diseases? Well, yes. I can say that whenever the list was updated in order to be acknowledged by the ministry, and considering the PCDH19 being considered as a rare disease, well, we were failing, because adding a new disease, a rare disease, means that costs go up, the cost soars, and you have to have a good standing so as to have your disease be listed in the official list of rare diseases. Let's have hopes for the next round of updating that list, because right now this has not been one of the priorities of our government. Professor Vigevano wanted to take the floor. Oh, yes, I asked for the mic when we were referring to the treatment. So let me go back to the treatment point. Now, the concept is that we have to start from one consideration. This is an epilepsy which is very, very special, very unique. I don't think that there are any other epilepsies having any such traits. So this is the reason why we call it PCDH19 girls clustering epilepsy, because this is an epilepsy which is expressing itself with a cluster. And in the case numbers shown by Marina, I think we go as high as 85%, meaning that they have 85% of the cases having a cluster, and only a cluster, nothing else. While here we have some also other isolated seizures or crises. And if those who still go on having crises or seizures still have some clusters they have clustering patterns. And in this morning's presentation, we've heard that after some 15 years, there were some patients having clusters on a yearly basis or a 6 months period basis. And that is running the risk of being a sort of a damage to the patient. So we need to find drugs that reduce the cluster. So we have to work on a protocol which is trying to improve that situation, which is cluster related. And that is a procedure that starts at home. It may entail that the patient goes around with its own dedicated program, which is also what happens for the Dravet patients. It can happen in Rome, but you could even have or be prey of any such seizures when you're on holidays. And that means that if there is some other way to treat in the best of the ways the cluster or the status epilepticus, meaning that we are trying to reduce the so-called potential damages and impairments provoked by the status epilepticus. Another mother, and then I will ask a question on behalf of a mother who wrote the question. Yes, very quickly. I would like to know something about data, just to have a better chance of interpreting what you said about the register. So I would like to know after how long patients are being considered seizure-free, and if in a well-being period, even a long-lasting period, say 4 years, a cluster of seizures, which is well motivated by the events, may be considered as a interruption, so the patient is no longer considered to be seizure-free. And then one more thing is I would like to know whether there are any further data available as to the incidence of hormonal phenomena or factors affecting seizures or involving seizures. We know that the dividing line is the one of the corresponding to the age of 14, that is puberty more or less. And I would like to know whether seizures have some sort of correlation with periods or with hormonal changes in general, and if there are any remedies with that respect. Let me give you a very quick answer to the last point. That is the correlation between the intercritical frequency and the premenstrual period, and in some cases even in the period of ovulation. Well, this is something that we see in many forms of epilepsy. This is not something which is only connected to protocadarin. And we also see it with the adult Dravet patients. Sometimes it's not fever favoring the seizures, but rather the premenstrual period. So there are conditions and preconditions or factors that have an influence, especially with epileptic subjects where there seems to be a close correlation. And in some cases, we also use a progestin drug to improve this aspect in highly selected cases, because we have to make a good assessment of the pros and the cons of this thing. And then, with respect to the first question, I would like to say that yes, when a cluster takes place, that's an interruption of the seizure-free period. And whenever we do record the follow-up, and we register into the registry on a yearly basis, which should be considering the period of the past year after the past follow-up and considering whether it was free or not from seizures. And then let me go back to what we said a few moments ago about drugs and side effects. I believe that this is also applicable to protocadarin, but also for the newly diagnosed epilepsies. We well know that sometimes the symptoms of a same disease, which are represented by seizures, by cognitive disabilities or difficulties, tend to have the same kind of onset at the same time. And sometimes they're mistaken for side effects instead of considering that there are some cognitive impairments which depend on that baseline condition. So the approach has to stay the same, and I believe that the orientation is exactly this one, especially when considering what happened in past years. So we have to establish what epilepsy is, and this has to include the neuropsychological assessment. We don't know what the evolution of seizures may be, and not even the neuropsychological evolution. So the two things are sort of in part independent one from another, and in part they are not. But in order to have a clear picture of what's happening, we resort to the guidelines, but the diagnostic understanding of epilepsy requires the assessment of the neuropsychologic condition of the patient. Now, as patients, we do not have an emergency unit, but whenever we see children undergoing 4 EEGs in 6 months and who have never been submitted to a neurological evaluation, well, we see that this is messing up the beginning of the treatment, because that is the reason why we are having difficulties in understanding the right correlation existing between things and events. Well, as far as the certification of rare conditions and rare diseases. Now, mine is a question. I wonder how, in general, how are our children being certified? This is a question for parents. This is my own nagging thought. I wonder about these things. Sometimes I am tempted of asking for a rare disease certificate. Sometimes, in order not to issue such a certificate, we tend to diagnose and issue a certificate of Dravet syndrome. So epileptic encephalopathies, this is what we usually do, because with the previous agreements with the health ministry, which did not unfortunately allow for the listing of this disease within that official list, because that rare disease does not exist. This is why it's not listed. But we've been told that we could list it in the list of epileptic encephalopathy. It's not the Lennox-Gastaut. No, it's not Lennox-Gastaut. But we could refer to that encephalopathy to obtain the therapeutic plans. And I have a letter issued by the Ministry of Health and telling us that we have to refer to a given code which is associated to an epileptic encephalopathy. It's a generic name which is not associated to a disorder. Could you please give us that code? Because probably that's a translation of the code. Maybe it's an individual translation, because the only generic code could be the one of different or other genetic disease, other than epilepsy, I mean. Because an epileptic encephalopathic disease is a code that does not exist. Well, later on, I will find it, I will show you the email that I received, and I will tell you what the wording is, the exact wording. I think it's fundamental, because after that we will have to see to which disease it's been matched, because the epileptic encephalopathy are the West and the Lennox. There is nothing else in terms of encephalopathy. Maybe I'm mistaken, but I will tell you later on. I will go and take a look at the emails. I have to go and glean into the emails. This is what I do. There are some rare diseases due to unbalanced chromosomal, genomic unbalanced rearrangements, which is a very rare disease, the RMG90. That's what we do, because that's not including so many conditions. I don't know what this may be helping us for. And in the very moment when you have a well-defined syndrome, you also have a series of tests that you have to take. But whenever you see such a thing, I believe this is what I do, and I think that this is also the right legal approach. In Lombardy, we have something that covers everything up to the age of 14. But for those who are not living in Lombardy, please mark down RMG 090. That's a rare condition which is including sort of bundling a number of traits, and which could be useful. So RING 090. I think that this is what it said. That's a code. So if you add 090, you bundle in so many other conditions, rare conditions. Whilst the 100 is also inclusive of other cases. maybe for that rare condition, for your own condition, for your own pathology, there may be a list. This gentleman is not realizing that he's not speaking in a mic, so I'm sorry. I'm doing my best. So we have to change our voting system so as to change things. I would warmly suggest that the 090 code is much better off. Now, obviously, I will not vote. Obviously, I am only voting one side, politically speaking. Now, I have a question from one mother. She's the mother of a girl of 15 years old. And she says that the seizures of her daughter have been changing in the course of time. And right now, she's now displaying apneas and stiffening of the body, which was unprecedented and that are preceded by tremors, and she shakes and she blocks herself. She's frozen. So I wonder whether these types of seizures or behaviors are common traits in other girls having the same condition. Is this something that has already been observed with other girls? Marina. I believe that this is a recent kind of trait. Yes, this is a girl aged almost 15. So this usually happens when the menses are about to come. And so these seizures could be probably the case. You have to start recording the seizures. And if these traits are different and new, the parents should take home videos. They should record them, take mini videos so as to make sure that the manifestations are not psychogenetic or psychogenic kind of manifestations. One very last question. We are exceeding the time limit. Let me just say one thing. I believe that in the framework of the study of the mechanisms of the drugs and their cerebral consequences is remarkable, but I believe that the Western medicine is extending its own horizons and considers the central nervous system as something which is not only made by the brain but also by the gastrointestinal tract. So whenever we consider the autism studies, the intestine or the gastrointestinal tract was given incredible importance. Now, as far as my experience is concerned, and I've seen this with my son himself, I've seen that the gastrointestinal tract is very important. And my daughter, after drinking, for example, milk, she would sort of trigger. That would be the trigger for seizures that would take place after 2 or 3 hours. So she had sort of ups and downs. And there were moment yes and moment no's, the so-called yes moments and no moments. And I would say that the no moments sometimes did correspond to moments of mismatch, where the body was mismatched and where the intestinal condition was rather compromised. There were moments and periods when my daughter had a terrible halitosis. She had intestinal problems, and the drugs that were administered were not effective. So I would say that maybe more than a question, what I'm now saying is sort of an invitation to considering this other aspect, which I believe plays a role. I have to stop you, Adriana, because tomorrow we will be discussing about the relationship existing with the GI tract and the brain. That's a well-known relationship and which is now been credited by the epilepsy experts. So tomorrow we will hear more about this. One very, very last question. This is for Professor Vigevano. What or how would you say we should intervene at the time of the first seizure of a cluster to try and stop it and interrupt it? What should we be doing? There are similar cases with the Dravet patients. There are similar traits. For example, what we do, we are using midazolam per os or rectally, and we are not waiting for prolonged seizures. We should consider the cluster as if that were to be sort of a prolonged seizure, and that's the first thing I would say that needs to be done. And then we should have reference places where we should go and address ourselves in case of a prolonged seizure or crisis. So you have to take action, and you have to intervene on the cluster, not on the prolonged crisis or a seizure. I think that may be very important.
Finiamo qui e
So let us end our parents' feedback session and move on to the next session, which will be moderated by Patrizia D'Adamo from San Raffaele Hospital. She's a dear friend, and she's here because of that. And she, as I said, will be moderating the next session, which will feature presentations by Stefka Tasheva, University of Adelaide, I hope I pronounced your name correctly, and Jack Parent from the University of Michigan.
grazie.